Hi, I'd like to welcome everybody to our webinar today. This is a webinar series directly targeting nursing home social service staff, but also welcoming nursing home staff in general and people who are advocates and folks who are just interested in learning a little bit more about social issues in the nursing home setting. I'd like to acknowledge the Retirement Research Foundation for their support for our webinar series. We feature social work speakers, but we also include speakers from other disciplines. And for people who are here on the webinar today, live, so to speak, we'll be emailing you a certificate of attendance. It'll include your name and the number of minutes that you were logged on to the webinar. We are recording today's session, and it will be available on the University of Iowa School of Social Work's website. And so that URL is right below there. It's the same place that if you wanted to, you could get the handouts for today's session are also saved there at the University of Iowa School of Social Work's website. I'm going to, in a few minutes, hand the phone over to my colleague, Bob Conley, and he will introduce today's speakers. And our speakers will have about 55 minutes to talk, and we'll then save the following 15 minutes for your questions and your comments. So if you have any questions, please, for our speakers, please put it in the Q&A box on the lower right-hand side of your screen. And if you have some kind of logistical issue that's making it hard for you to hear or whatever, send me a note in the chat box. I'm your host, Mercedes Byrne-Klug, and I'm here at the University of Iowa, and I'll be watching that chat box throughout today's session. At this point, I'd like to introduce Bob Conley, social worker with 20 years of experience at the Center for Medicare Medicaid Services, and in fact, Bob was the project officer for the MDS 3.0, so he knows that document inside and out, and he's very interested and committed to seeing how that document can be used to improve care planning. Before going to work at the CMS, Bob was a hospital social worker. So he's an integral part of this committee, and he is going to go ahead and introduce our topic and our speakers.
Thank you so much, Merce. Today's topic is non-pharmacological approaches to managing challenging behaviors in dementia. And we know that right now CMS has an initiative that is really monitoring this, has given each nursing home in the country the hand-in-hand materials that provide videos as well as training materials so that it's a national focus. Today we're really excited to have two excellent speakers who are going to give a presentation on this important topic. The first is Lori Nisson Waldberg. Lori is a licensed independent clinical social worker and has spent 20 years specializing in working with adult and senior clients experiencing emotional, cognitive, and behavioral problems. Lori and our second speaker, Robin, are in Arizona. Lori has provided behavioral and dementia care consulting at hospitals, outpatient programs, and long-term care providers, so she's really an expert. She is the clinical director of Dementia Behavior Neighborhood Choice Rehab Care and is joining the Banner Sun Health Research Institute team and will be offering individual, family, and group therapy and behavior management. Lori believes strongly in community involvement and active participation in Alzheimer's Association and is an active member of the Area Office on Aging Advisory Board. Our second speaker, who Merce and I have worked with for a number of years, is Bonifas. She's an assistant professor at Arizona State University School of Social Work. And she has over 15 years of experience working with elders and their families, both long-term care and inpatient psychiatric settings. Some of you may remember she did a wonderful presentation on this topic in December member and has been invited back for good performance. Her research focuses on psychosocial care for persons with chronic illness and disability, those with comorbid mental health conditions, and those requiring nursing home care. She's also been doing a lot of work in interprofessional education with students to really develop competencies in collaborative health care practice. John Hartford Scholar in Geriatric Social Work, and she earned her doctorate from the University of Washington School of Social Work in Seattle in 2007. She serves on the board of directors for the Association of Gerontology, Education, and Social Work, and as a consulting editor of Health and Social Work. So I believe Robin will be the first speaker, so I'll turn it over to her. Thanks.
Thank you, Bob. And thank you to everyone who's here. We have a huge national audience, I see, with 92 people, so that's wonderful. We're really glad to have you join in. So the objectives for today is for people to first understand some of the regulatory guidelines that help us with how to approach challenging behavioral symptoms. And I think people are probably aware of the regulations, but it helps to have a reminder of those. You can know about it enough. At the end, that you'll be able to identify some of the common behavioral problems that arise with people with dementia primarily, and that you'll have some ideas about effective strategies. And we're hoping we'll gain at least 3 more new strategies that you can employ in your practice for managing challenging behaviors in the context of dementia, and then creative ways, 3 new creative ways that you can offer care to residents with dementia. So on that note, I'll go ahead with the regulatory guidelines. And again, it's just to help seat the presentation within the context of regulations. And that can be helpful sometimes because we know as practitioners that the right thing to do is to do non-pharmacological interventions first, but that may not be the case with all the colleagues that we're working for or working with. And sometimes thinks, oh, that's just a nice thing to do, and meds are really where it's at. And when it happens, when we're really solid understanding of regulations, we can sometimes help bring people on board by reminding them of what the regulations have to say about this. So basically, our regulations that guide nursing home care mandate that we first address challenging behavioral symptoms with non-pharmacological interventions rather than pharmacological. So we need to try those behavioral interventions first before resorting to medication in most situations. And the prime focus of our webinar today is to look at those types of interventions. So I'm just going to briefly go over some of the regulations, and it's not meant to be exhaustive, but just to remind us of some things we're held accountable to. So I'm going to talk about FTAG 329 and FTAG 330, and 29 is unnecessary drugs, and 330 is antipsychotic drugs. So remembering that the purpose of the legislation and regulations around unnecessary drugs is just to prompt us to do a differential diagnosis. So then we see behavioral symptoms, we're not automatically thinking, oh, it's a psychiatric problem, we need to use psychiatric medication, but to recognize that most behaviors occur, something is causing that. There's an underlying cause. It's not just because the resident decided to be touchy that day, but something's going on that triggered the behavior. And part of our job is to get, well, what was that trigger? What's the underlying cause? And the idea is that we don't ever want to resort to psychotropic drugs when the behavioral symptom is caused by environmental stress, by psychosocial stress or treatable medical condition. And I don't know how many times I've seen someone prescribe Van or Haldol or something like that for behavior that's caused by a urinary tract infection. And, that's the kind of thing the regulation is trying to avoid. So the language for Tag 329 about unnecessary drugs, and the idea is we want to keep residents free from anything that's unnecessary, and that term is broad. It can be something that's in too high of a dose, used for too long, something that's perfectly with requirements, perfectly within appropriate time, but we're not monitoring it, or something that doesn't have adequate indications for its use. And now there is that phrase, without adequate indications for its use. So if we haven't done pharmacological interventions first, haven't tried that to reduce the behavior, we really don't have the evidence that we need that the medications are necessary. So trying behavioral interventions first and documenting their effectiveness or ineffectiveness, sometimes it's both. They help in some ways but not in others. Having that documented provides the indication that we need if it does get to the point that medications are necessary. Here's some medications that we really want to be aware of in terms of psychotropic medications that can more easily be seen as unnecessary drugs, your benzodiazepines, your anti-anxieties, hypnotics, and antipsychotics, of course. So with the benzodiazepines and anti-anxiety medications, regulations are very clear that we can only use those in certain contexts. Of course, if somebody has a generalized anxiety disorder, we want to be treating symptoms. But in the context of delirium or dementia or these other cognitive disorders, the have to be quantitatively and objectively documented, and they have to be causing the resident distress or dysfunction, or be distressing to other residents, or put the resident at risk. And they have it bolded there, persistent and not due to preventable reasons. And that is a call for doing our behavioral interventions first, because if we haven't tried behavioral interventions, then we don't really know whether the challenging behavior is persistent or preventable. So that can help us to meet the regulatory guideline too. Now, in terms of FTAG 330 and antipsychotic drugs, we should never use antipsychotic drugs for all these behaviors listed here, and I'm not going to, read all of those. The idea about, wandering, impaired memory, insomnia, and sociability, fidgeting, nervousness, uncooperativeness, all kinds of behaviors are concerning, of course, and we want to have interventions, but it's not the place for antipsychotics. So the idea of all the behaviors listed on, this slide that here, all these behaviors, they're all appropriate for non-pharmacological interventions, so behavioral interventions, and that's what's the stage now for the most, I think, key part of our webinar this morning is learning about some of the factors that contribute to behavioral symptoms, and then how do we do interventions? What are some key non-pharmacological interventions? And that's where Lori is going to teach you all kinds of wonderful things about that.
Thank you.
You're welcome.
We about culture sensitivity in dementia care. I think what Robin's saying, really one of the things that is most important is that we're coming from a platform of sensitivity. So dementia affects somebody's ability to manage their environment and to communicate effectively, and so we once were looking for that pleasantly confused person, we now know that behavioral changes are really part of the disease process. 80 to 90% of people with dementia are going to have some form of behavioral disturbance in the core of their disease. And you have family members saying things like, well, my mom's always been really difficult and she's just giving you a hard time. You know, that may have been part of her personality before, but now with the dementing process going on, these behaviors are typically not volitional, and they really require us to do a better job to anticipate needs and to use compassion and empathy, which is sometimes difficult when we have a behavior that's very disruptive both to that particular resident as well as other residents around them. So keeping in mind, I'm a behaviorist, so my idea is that behavior has a purpose. And as Robin said, arguably in most cases, really our approach to the behavior, our behavioral intervention, how we try to de-escalate that problem first, is critically more important than using medication as kind of a Band-Aid. So often people with dementia are demonstrating a need. Somebody who's taking out their clothes maybe is showing that they're bored. Maybe that's something that is a trigger that they need to be more productive. And try to consider what that person's need is and trying to accommodate it, finding a structured activity that focuses on activities that they've enjoyed or done through their homework or work outside the home is really going to be much more successful. So we know that a lot of behaviors we see are very difficult and very challenging, and it's really difficult for us to figure out what is during that behavior. But what we have to do is try to use different approaches at different times, and it can be difficult at times to be creative and flexible when you have multiple residents and the behavior is very disruptive. So with that, in the middle phase of dementia, we see the most types of behaviors. And when we're talking about long-term care, particularly in nursing homes, we typically are seeing people in the middle stage of their disease. Earlier in the disease, we're often seeing more of the emotional symptoms. That like turn sundowning really just talks about the idea that as the disease progresses and as the day progresses, that person's behavioral symptoms may escalate. So that's in a very tricky situation because some of the solutions that we find that work on Monday don't always work on Wednesday. And as the person's disease progresses and changes, we really have to be creative and flexible in our strategies. So the common types of behaviors that you all know and that Robin covered some of are ones we see quite a bit with people with dementia. So we have to remember that in understanding behavior, the brain is affected. And so that person's ability for insight and judgment is really impaired. In my outpatient practice, I work with a neurologist who diagnoses dementia, and he often sends people into my office after they've been given a diagnosis. And I like to say that 2 out of 10 of those people will walk in my office and say, Lori, I just was told I have mild cognitive impairment or early Alzheimer's disease, and I'm very angry, I'm very sad, whatever the emotion is, and we can process it. But 8 people walk in my office, the other 8 out of 10 walk in and they point at their spouse and they say, I don't know what I'm doing here. He or she is the one with the problem. So the point is that often that person really has limited insight in their ability to understand that they have a dementing disorder. It affects their judgment as well. We know confusion of ability affects someone's ability to understand their surroundings. So a confused person will often act out just because they're fearful. They can't express themselves. They can't clearly tell you to stop. And even though you may have already told them who you are and what you might be doing, the short-term memory is so short that just a few moments later they've already forgotten that information. And that puts us as care providers in a very precarious situation because people with dementia, as they progress through the dementia and become more and more impaired cognitively, they also become more physiologically challenged, right? So they have incontinence and they need help with bathing and dressing, and so it puts all of our care staff in our facilities in a tricky situation because we have someone who doesn't understand that they need care, but they require a lot of hands-on care. And so it puts CNAs and nurses and all of us in a position of being intrusive and often limiting privacy. So we know that because someone can't conventionally express themselves, they may have a great deal of physical pain. People at age, of course, have more and more physical pain. And people with dementia, instead of being able to say, hey, I have a headache or my back hurts, that pain may be demonstrated through their emotion of irritability or anger or frustration. Robin, talk a little bit about some of the research on resident-to-resident aggression.
Thank you. I just wanted to let folks know about some results that came out recently from my study related to the linkage between resident-to-resident aggression and pain. We figured there would be some type of association, but what came out in the numbers is an association in the unexpected direction. So what we found is that the greater the intensity of pain, that's associated with fewer incidents of resident-to-resident aggression. We thought it would be the opposite, that the more pain you have, the more aggressive you are. But what we did find is even though people in more pain have fewer episodes of aggression, the ones that they do have tend to be more severe. So that there to be more of a potential for injury there. So it's just sort of an interesting dynamic, interesting association there between the linkage between pain and resident-to-resident aggression for you to be aware of.
So pain, we know that, as people age, and particularly people with dementia, are susceptible to infections. And it's difficult to discern what may actually delirium and what's the underlying dementia. And so we know that if someone has kind of a baseline level of cognitive impairment along with their behavior seems somewhat stable, if we see that abrupt change in their behavior, typically an escalation, we definitely want to take a closer look to see if it may be a delirium. And when we're looking at a delirium, we want to figure out what is triggering that delirium. Is it an infection? And I think we've done a good job in long-term care of better assessing a urinary tract infection or pneumonia. But we also know that if the person has a recent change in medication or increase in medication dose, that could trigger a delirium as well. So the things we look for in a delirium would be that acute and rapid change in their personality, their mood, their thinking, and we often will see psychosis, someone having visual hallucinations, grabbing at something at the air that's not there, or having an escalation even in their delusional thinking. So we really want to get the physician to take a closer look at what might have triggered the change in behavior. We know that environment has a big effect on someone's behavior. So if we have a very noisy environment, people are coming and going, we have an overhead loudspeaker, the TV is on very loud, that can cause people to have a spike in their behavior. It causes and triggers agitation. Change of environment can cause an increased behavior. So even someone who's been living in your facility for a long time, maybe a year or two, they go to the hospital for or maybe even a fracture. They come back to your facility and it's like a brand new place to them. They need time to settle back in. And of course we know an understimulating setting. This is why I think activities are critical, really lead to behavioral disturbance. So you think about if you were someone who was living in your care facility and someone got you up in the morning, got you dressed, put you in your wheelchair, got you seated by the nursing station, and you went out to lunch and then you came back and you were still sitting at the nursing station, several hours later, how would you be feeling? How restless might you be? So knowing that people with dementia require, that fine balance. Really, we need to reduce external stimuli when we can, external noises if possible, but also provide some structure and activity. think about agitation and wandering, often some of those environmental sounds are triggering it. We know that there's an ongoing battle in care centers, right? The staff are always running around taking care of residents, so they're exceptionally warm and they want that air conditioning blowing. And we know that our older residents are typically always cold. So we have to be aware that that person may be too cold or too warm. When we see someone who's fidgeting or wandering around, is that maybe an indicator that they need to be toileted? And we know that, of course, wandering, as Robin pointed out, is not a symptom that should be medicated. That's where we need to find or modify their environment, find a place where they can be in a secured setting so that they're safe. Some other things that change with people with dementia is that they have some visual spatial changes. So sometimes things like stop signs on a door can keep someone out of that room. A dark rug or even painting a mural over exit doors can really distract somebody from wanting to wander out of an exit door and keeping them more safe. So people who are restless, even people who don't ambulate on their own, but sit in a wheelchair and they don't remember that they can't walk on their own, they're restless to get out, they're restless to get moving. So it often takes more staff time, but it's important if that person can ambulate, if it takes a staff member to assist them, that we get them walking, because it really reduce their level of agitation. Of course, always introducing yourself. And some of these tips, too, are ones that you know, but ones you have to kind of coach family members on who think that the theory of use it or lose it applies for dementia. So if I don't test mom on my name, she'll never remember it, instead of knowing that the approach of prompting her is going to lead to a much more successful outcome and much less agitation. So if people with dementia who have agitation aren't given any kind of structured activities, particularly early in the day when they may be more alert, we know that they will often become restless from boredom. You have to do tasks and help out these folks even when it seems trying, assisting people in looking for missing belongings, allowing people to carry their Linus blanket. Maybe it's their old wallet, a few dollars if it makes them feel more comfortable. So keeping track of behavior is really important, right? Some facilities do that in the MAR, some do that in the actual chart. But sometimes when we take a look at the behavior, we can find a trend. Is it always that person is agitated late in the day? Maybe they aren't getting enough exercise early in the morning. Is it that they wake up grumpy and crabby and maybe they're stiff from arthritis that we could be treating with Advil or Tylenol? So we have to kind of be detectives and figure out what may be causing that trend. So we don't want people sleeping the whole day because, of course, then that impairs their ability for their natural cycle to sleep at night. But we do know that people with dementia have a lot more fatigue, so they do need naps. So being aware of approaching that person from behind, not startling them, and the old, hallmark idea of dementia care of really redirecting and distracting people out of stressful situations. So the idea of, instead of saying you can't go here, instead of saying no, we're kind of shifting our communication to say, let's go this way. So we thought some of the challenging behaviors that we see in long-term care, often calling out behavior can be really challenging. It's distressing to see that person calling out and upset, but it's also distressing to other residents. You might hear other residents saying, hey, shut up. And you know that people with agitation can often cause a contagion, right? The whole room starts out calm and one person's calling out, and the next thing you know, a lot of people are agitated and restless. People who call out are often people who are wheelchair-bound, who can't ambulate without assistance. Exercise at any level can often reduce agitation. If they can't ambulate, make sure they're repositioned. I'm the clinical director of a dementia behavioral program, and one of the things I required that our nursing home administrator purchased before we opened our unit were some recliners, because I have had some success with people who are in a wheelchair all day who have a tough time walking, but really get feeling uncomfortable sitting in that chair all day and can be in a recliner and really enjoy that level of comfort. Person may be experiencing agitation or anxiety by being separated from a loved one or feeling like they need to have someone near them. So even placing a resident who has that level of anxiety near you, even if you're charting, can often soothe that person just having you within arm's reach. People call out, sometimes some hard candy can be useful in keeping them distracted. But often these are folks who have some undiagnosed physical pain, so we have to consider whether the physician might want to prescribe something over the counter, or if it's something more severe that needs to be treated. Physical touch can be soothing to somebody who calls out, a hand massage, using that sensory connection of lather or eucalyptus. Soft music or relaxing tapes. We've had some success on our dementia behavioral program of purchasing some real inexpensive $15 MP3 players and customizing the music on that MP3 player for that particular resident. We have one resident who, at the stage of his dementia, only speaks Arabic, and so one of our staff had downloaded quite a bit of music for him in Arabic, and for him that really seemed to suit him. He was somebody who liked to be on the go a lot, so we were able to clip it on his shirt and give him some headphones, and he seemed to accept it and really seemed a lot less distressed. The research that bird chirping or other nature noises can reduce verbal calling out. So if someone is becoming very angry, often using a respectful kind of directive tone, often using a little bit of formality by calling that person Mrs. or Sir in order to show respect for their authority. Being aware of things that might trigger someone to feel that you're talking down to them, not asking somebody to relax per se, but using different language. I think what is sometimes very difficult about these behaviors that we see with dementia is that often, care staff say, well, yes, Lori, that person is just acting very childlike. And that is true. Some of these behaviors do seem childlike. However, we want to, reinforce that idea that we need to show respect for people, that they're people who have lived long, productive lives, and even though the behavior is childlike, we don't want to treat people like children. Physical aggression can be, of course, even more dangerous. It's very difficult to manage in a residential facility, taking that person to a quiet spot. If an altercation arises, gently guide peers out of the room without panic or anger. We sometimes see this between two people who have dementia. They both maybe have some sensory deficits. One can't hear the other one talking, can't hear what they're saying. There's a misunderstanding, and the two become, escalate into some kind of physical aggression. Chronic aggression, though, really is a signal that a psychiatric assessment is really probably most appropriate. Having some expertise from someone who can develop a behavior plan and a psychiatrist who may be evaluating that person from a psychological as well as pharmacological intervention is really going to be important. I think too, when verbal or physical situations arise, this is a good time to look back on your training, whether you have someone that comes in to do training for you or whether you're using some of the modules from the CMS hand-in-hand. It's really a good way to help staff get a better handle on some of these behaviors, because I think for for most of us, when we don't know or we haven't dealt with these kinds of situations, we really need a lot of training, a lot of support to be able to manage these behaviors more effectively. And we've all intervened with residents where we've walked away saying, wow, I did a great job, that was really an effective intervention. And we've all had those days where we walked away saying, maybe it wasn't the best intervention and maybe my behavior kind of escalated things. So constant training and learning is really going to help you feel more equipped to manage some of these behaviors. Robin's going to talk a little bit more about some of the research.
Yes, I've been doing research in resonant aggression in terms of how nursing and social workers are managing it and what they see as best practice, what's been most effective for them. So here are some of the strategies that they told me about that may also be useful to you that you might want to consider. So, and I think one of the things they shared with me is just the importance of including social work values in the overall plan, maybe behavioral management plan. And what they meant by that is really getting to know residents, knowing them as people, as humans, as folks who have this lifelong history that, like Lori has already shared, like with the music, that you need to know what kind of music the person likes and is appreciating now before you can really use that as an intervention. So they talked about that, and it's not only just the social workers knowing the residents themselves, but helping other staff members to get to know the residents. And they talked a lot about creating living social histories that really help to bring the residents to life for people. It's not just our traditional social history that we might file in the chart somewhere that no one ever sees, but things that are part of the residents' room that engage the staff in learning about them. So that was really key, they felt, in terms of how to manage behaviors. And they talked about the importance of bolstering interdisciplinary team effectiveness and communication, that having a solid team was really critical to getting a handle on behaviors, but at the same time also to ensure everyone on the team that their voice was heard. So it wasn't just social work and the director of nursing, but recognizing that nursing assistants have a lot to share, housekeepers have a lot to share, activity professionals have a lot to share. So bring effective communication was critical. Policies and procedures, they talked about that being very important, especially policies and procedures that prompt staff to be reflective in care. So just like Lori was talking about, hey, that intervention went well, that one didn't, and to be really thinking about what made the difference and incorporating that into practice. And so the critical thinking about our interventions and our assessments, and as social workers, fostering relationships with our interdisciplinary colleagues so they're comfortable coming to us when they have concerns about resident behavior, that they trust that something's going to happen with the information that they report. And then in turn, when we're asking some of them, they trust that, the social worker is trying to help. She's not trying to interfere or tell me what to do, but giving guidance and what might work for this resident. So the relationships were really key. And
I think to add to what Robin's saying too about really kind of understanding that person and understanding their preferences, you as a social worker may be the person that has the direct link to family members if they are involved, and so finding out activities that person used to enjoy, things about their past, so that we can use those tools to connect and reminisce with them, are really going to be really important, I think, to their success in integrating into the long-term care community, but also in finding things that they can find pleasurable and enjoy. And that's really important in terms of reducing their level of agitation and frustration. So as a clinical worker and consultant, I often get called in to deal with kind of behavior, that hypersexual behavior and disrobing, and that is because it is the behavior that makes residents around that person uncomfortable, it makes visitors uncomfortable, and frankly, it makes us uncomfortable, right? So the idea being that we want to redirect people with dementia away from peers that may trigger that kind of behavior. It may be that they have a misperception and think that that person looks like their wife. It may be that a CNA is trying to give that person a shower and they misconstrue the situation and think that it's some kind of romantic interlude. So it's a really difficult behavior for us to manage because we want to keep that person in particular safe. But we also want to respect that individual. For example, if they are self-stimulating, we want to not scold that person. We want to redirect them into a private place. We want to distract attention away from the problem. But because that person has a memory disorder, they're not going to be able to process or explain themselves, and they don't have the cognitive ability to necessarily correct that behavior on their own. So the goal is to really just distract attention away from the problem without necessarily confronting that person. Be aware of cues. Sometimes we have people who want to throw because maybe their clothes are uncomfortable. Maybe the temperature is too warm. Maybe it's that their clothing, they've lost some weight and their clothing is just no longer comfortable for them, or maybe it's too tight. Considering sometimes restrictive clothing, one-piece back-zip garments can be helpful for people who like to urinate in a plant, for example. We have one gentleman who used to wander around our dementia behavioral unit, and he is notorious for disrobing and urinating everywhere except in the toilet. So by using a one-piece garment for him, it looks like a pair of keys and a polo shirt, so it's still, risking his dignity. But when he starts pulling at the waistband, it triggers staff that he really needs some assistance being toileted, and they can redirect him to the appropriate place to do that. So distracting attention away from problem situations, again, that's where training and talking about these kinds of situations individually and in teams can be really helpful, because the more comfortable you are with the idea that these are kinds of situations are likely to pop up in your residential program, help you to not overreact in a situation like this, which can escalate or worsen the behavior. So paranoia is a common symptom we see in Alzheimer's and other dementias where someone has unrealistic fears. They often will really benefit from a psychiatric or neurological evaluation. Someone who has stopped eating or taking medications because they are fearful. Sometimes showing that person the food before you serve it, keeping it sealed, can make them feel more comfortable. And paranoia is just one form of delusion. And these are the terms that we kind of tend to get mixed up. So delusions are false fixed beliefs. So they're really a belief system. So the idea that someone has to get to work or pick up their kids from school when you know that really their children are grown. So we have to kind of step into that person's reality, because we know that somebody with dementia is not going to be able to be pulled back into ours. So it's important that we listen to what they're saying and not contradict them. And we also know that people who have sensory deprivation, which includes a large population of the people in our long-term care settings, right? People who have maybe macular degeneration, don't see well, or have really severe hearing loss, they're more apt to experience psychosis. So one of the residents will be sitting in the dining room and she hears someone laughing. She can't hear what they said, so she'll often personalize it and think that people are laughing at her and become very angry. So making accommodations in the environment when we can to increase comfort. The idea that we never want to argue with somebody with dementia. When I meet with family members who are taking care of their loved one who has dementia, I always say, you want to actually align with that person. And when you think about what that looks like physically, instead of sitting on the opposite side of that table from the person, you really want to be sitting next to them. And that's to kind of think about theoretically what it means to align with somebody, to really be on their side. So if your goal is to always align with them, that means you're never going to argue with them. Being right is no longer important. Reminiscing more about that person's work. Or if they're giving orders, respond as if you were an employee. If the person feels like they have to leave, this place isn't home, we don't typically gain much by saying this is your home now. If that person believes their home is a place they lived 30 years ago, this certainly isn't their home. And they need to be reminded that it is their home. A better approach might be to just ask questions. Where we're headed. How long would it take you to get there? And let them. You would help them get there, but maybe something is inhibiting your ability to do that. Jones, I would love to help you get a ride, but right now the buses are backed up. It's going to take us some time to get a ride arranged for you. Or it's really warm outside. I just came in. It's about 110 degrees. It's very hot out. So in the meantime, let's get something cool to drink and talk about it. And then try to distract that person with activity or with a different room or with something else going on to get them engaged in something different. And oftentimes a behavioral intervention is often enough to soothe or redirect the person. This can be difficult, of course, because the short-term memory is short, right? So the good news is they may forget where they were headed in the first place. The bad news is that sometimes you have to redirect them several times because they have the same idea that pops into their head. Hallucinations are a little bit different. They're actually sensory in nature. So they're a little bit less common in Alzheimer's disease, but they are very common in delirium. So again, if you have somebody who has dementia and all of a sudden their behavior changes and they seem to be escalating quite a bit more in terms of their mood irritability and their combativeness and hearing or seeing things, then that would definitely indicate a need for an evaluation from their physician. Experiences really can be auditory. They might be hearing noises or sounds. They could actually be seeing things that aren't there. Actually, I had one resident on our dementia behavioral unit who had tactile hallucinations. He would often scratch his skin because he would feel bugs on it. Seemed to be easily redirected if the nurse validated what he was feeling. Wow, that must be really comfortable for you. Let me clean that wound for you and put a bandage on it. And for him, that to soothe him. So seeing animals, I've had clients who have moved several times because they've smelled gases coming from the vents. Even hearing people on their roof. So not arguing with that person because you're trying to align with them. If they're seeking a dead spouse, you tell them, hey, this person's been gone for 20 years. What will happen? You're going to grieve the loss, and term memory is short, so a few minutes later when they ask you again about your husband, are you going to tell them, hey, we mentioned to you that he's been gone for 20 years, and that person will start grieving. I mean, we easily argue that having someone grieve all day is not going to be in their best interest or healthy. Or the opposite is true. If you tell them that their spouse is gone, they might think you're lying to them, and now you've disaligned from them. So again, I like to try to tap into what the emotion is. What are they feeling? If they're looking for their husband who's gone, often what that's really saying is that they miss that person. So I'd say you really must miss him. How did you two meet? Ask long-term questions because, as we know, as the memory dissipates, the short-term memory goes first. But long-term memories may stay a lot longer. We can use that as a tool for reminiscence. Sometimes all you can do is just provide reassurance. That must be really scary for you. Or how can I help? We see psychosis at times, particularly delusions in the middle stage of Alzheimer's disease, but we often will see hallucinations in delirium, or even the early stages of Lewy body dementia. If that psychosis is really distressing, ongoing, or really impacting the activities of daily living, and we've already tried all of our behavioral approaches, it may be, again, that we need to have the physician assess what kind of intervention. It may be that a pharmacological intervention may be appropriate if we've tried everything else first. So a vignette on a previous actual resident situation in a nursing home and a dementia unit. Maria is an 85-year-old Italian-American widowed female. Diagnosis for the behavioral program is dementia with behavioral disturbance. She's ambulatory. She looks actually a lot younger than she is. She does require some ADL assistance, dressing and bathing. She has a very impaired sleep cycle, so she'll sleep half the day, even though you try to keep her awake so that she'll sleep at night. Our efforts are often very challenged with her. She also has some medical symptoms, including osteoarthritis, which causes her pain, and advanced foot bunions, which are causing her some discomfort too when she wanders too much. Of course, we want her to sit and put her feet up sometimes, but with someone with dementia who is more restless, that's a difficult to accomplish. So she has some behavioral challenges as well. She has an impaired sleep cycle, as I mentioned. She often has mood lability. We suspect that, as a younger person, she likely had a diagnosis or symptoms of a bipolar disorder. She can be very friendly one moment, and later in the day seems to be cycling into a lot of anger, frustration, yell at staff, will misinterpret a verbal intervention from a peer and become very angry with that person. She does have periods of agitation and pacing, and even though she emigrated to this country years ago and spoke English fluently, now she really speaks a blend of English and Italian. So we know with dementia, and she's in the middle stage, advancing forward, that people really start to lose their short-term memory, and sometimes that aphasia, that language disturbance, includes the languages that they've spoken here for 30 years. So the challenge with Maria is that we see anger, some verbal and string of anger directed at staff, even at peers, scolding them. We have psychosis where she believes some peers and staff are her family members. She'll occasionally befriend a male staff or a male resident and believe that he is her husband, which can be very distressing. If it's another resident, we have to gently redirect her. And there's one particular staff member, a younger CNA that works with us, that she often calls Paige. She thinks it's her granddaughter. She sometimes believes people are in her home and she wants them to leave, so she's trying to kick them out of our area. And these behaviors can be really challenging on a smaller dementia program. Thinking about the approaches that you might use to manage her behavior. If looking at it from a behavioral perspective, how might you intervene to try to de-escalate some of these challenging behaviors? What will she do when she's angry? If it's directed at a staff member, he or she might feel really comfortable redirecting, but if you have her very angry with another resident, how difficult might that be for you? Approach her erratic sleep cycle. Do know that, having her sleep during the day and awake at night can be very difficult because it can be disruptive, but we also want to really be aware that, if we gave her a medication for sleep, it could have other side effects, make her more confused, make her, since she likes to wander, a higher risk for falls. And so what kind of behavioral interventions might you try to implement? So think about some of those things, and knowing that Maria has a strong background. She was raised Catholic. One of the things that we used very successfully with her was to bring in her and say prayers with her. That would often soothe her. We also would implement use of the recliner for her in order to allow her to be awake at night but try to get some rest for her legs. She also really seemed to enjoy operas. We tried using an MP3 player with her, but she felt very confused by having headphones on and would tear them off. So we would have to seat her in the recliner next to a CD player to play the tenors and other music that she really enjoyed. I think those are some good examples and some suggestions on how to manage some of the challenging behaviors. And maybe we'll move on to hosting some questions.
Okay. Any questions or comments, please go ahead and put them in the Q&A box. I see that there are some questions about the certificates of attendance, so I'll address those while people are typing in your other questions to Lori or Robin. The certificates of attendance, I'm hoping we're going to get caught up with those by this Friday. So I apologize. Our February certificates did not get out in a timely manner, but they should be out by this Friday. You'll be emailed a certificate if you were part of the live webinar. Okay. There's another question. Can we get a copy of the slides? Yes, the slides have been saved as a handout, and you can just Google the University of Iowa School of Social Work. And when you get to the University of Iowa School of Social Work webpage, look for Nursing Home Social Work. And all the handouts for all our webinars are there. Any questions or comments about information we heard today from Robin or from Lori? We'd be interested in if this was helpful, if you have any clarifying questions, if you think you'll be able to use any of the tips from today. I was listening to Lori in particular. I was reminded of some of the basic principles of the Montessori method, right? That you take where usually it was developed for children, but you take what the child is interested in and you try to distract that child away from negative behaviors or dangerous behaviors by helping them and supporting them and following their interest. So I think a lot of these good interpersonal behaviors work with ages. So our questions or comments. Robin, is there anything else you would like to say?
Well, she wanted to share with everybody.
Okay. All right.
I think what you're saying about, finding activities and sensory stimulation is really critical, because as people with dementia are less able to communicate verbally, we have to find other ways to connect with them. And so often the most effective ways are through a sensory approach. So whether we're using touch if that person tolerates and is comfortable with that, or whether we're using some kind of stimulation to connect with them, whether it's music, or whether we're finding some kind of scent that's pleasurable or calming for them, like lavender. We really have to kind of be creative in our approaches.
There's a question that's come in. You've addressed resident to resident aggression, but what about resident to staff aggression? How would you suggest handling that?
A resident to staff aggression, again, doing some crisis training is really important. There's a model that a lot of human service organizations use to do training on how to avoid or get out of situations where someone's aggressive and you cannot or do not, of course, want to retaliate. The CPI model, Crisis Prevention Intervention, has really good physical de-escalation techniques to help staff feel more safe in the workplace. So I would encourage you to check that out.
Okay. I do have a comment in. I do not work in a nursing home, but I'm an educator for Bachelors of Social Work students. I learned a lot that I'll share with my students. Thank you, speakers. So pass that on. And then there's isn't that great? We're getting information to the undergraduate students. A question from Debbie. I have a resident who says she's scared, and no matter what I do, she keeps saying she's scared. So what advice do you have for dealing with a resident who's persistently scared?
I have to try to find out what she is fearful of, and you're having a tough time with that, meaning she's unable to communicate with you or can't tell you or maybe can't even identify it herself. It may be that she would benefit, maybe she has some anxiety and would benefit from sitting closer to a staff member. It may be that she would benefit from using some deep breathing techniques if she's able to do that. It may be that you just have to reassure her. Sometimes we don't have a magic wand, but what we can do is reassure people that they're safe here and that they're okay and that we're here to make sure that they're safe and that we wouldn't let anything happen to them, that we're going to take very good care of them. And then, if at all possible, I would try to distract the resident with some kind of activity. It may be that you give her even a job to do if she's capable of, folding and putting things in envelopes for you, or giving her things to keep her hands busy, and playing some soft, relaxing music in the background.
Love ideas. There's Bob, you're unmuted if you have a question you'd like to.
Yeah, I did. Thanks to Robin and Lori with so much practical suggestions. It's really been a very worthwhile presentation. Robin mentioned social history is important, and we're going to have another later in the month on dementia, and the same of the importance of social history is going to come up. And having worked for about 14 years in either a PEDS intensive care unit or a oncology unit or a hospital, the role of the social worker as the connector to the family and as the reflecting on more of the social history and then kind of the family dynamic is so critical. And I wondered, when you were talking, Lori, about sexual disrobing or inappropriate, how you recommend dealing with a spouse whose husband is doing that, perhaps with another female resident, in terms of children who might even be embarrassed or at odds with each other or judgmental. How some techniques the social worker who plays a pivotal role in that might think about.
If a resident who is hypersexual to someone else? Okay. The best case is to really explain to family members, too, about dementia and how it affects someone's ability for insight and how often people perceive other people as someone that's familiar to them when really they don't know them. Explaining to families to help them better understand dementia. But if two residents are holding hands, for example, and both are comfortable with it and families are okay with that, it may be that behavior is okay to continue. They may sit together and seem to enjoy each other's company. But we also have people who have dementia, so something beyond that, like something more physical, like kissing or some kind of sexual behavior, of course, would not be okay because that person has dementia and they aren't really able to consent to that kind of behavior. So that may be a situation where you really have to separate the residents in different parts of the building, if possible.
Thank you.
Another question came in. Thank you for your response to that one. Any tips for enlisting the support of nurses and CNAs to use the techniques that you talked about today? Sarah sent in that question.
I'm talking about that one. This is Rob. I know in my research that what social workers found to be really helpful in order to get CNAs and nursing involved is to really to work on relationship skills with the nursing staff. And when there was solid support relationships between nursing and social work, there was much more buy-in from nursing in terms of trying ideas that social work suggested, and often we're working together in teams around these issues. So licensed staff and CNAs and social work and activities sitting down in a group and talking about, the challenge we're having in terms of disrobing or this, that, or the other thing, and everyone was equal member of the team. And when the social worker was honoring what the CNA had to say and what the housekeeper had to say, it just seemed to promote more of a cohesiveness and more of a willingness to then try out some of these ideas. So it's primarily, to me, from my research, it seems all about collegial relationships and good communication. Not that that's like easy. You don't just wave a magic wand and have it happen. It's a process of building those relationships and those trust between the disciplines. Laura, do you have more to add there?
Yeah, I was going to add, I completely agree with what Robin is saying, and also I am someone who writes a lot of behavior plans, and so I'm writing a behavior plan for somebody with dementia. My goal is not to shape their behavior, right, because they have dementia and can't comprehend those changes, but it's to change the behavior as us as care providers. And so I see myself as a facilitator in that process. So to add to what Robin is saying, the people who have really, frankly, the best information about that person's likes, dislikes, and techniques at work are typically CNAs. So by involving CNAs and nurses, of course, in that process, you get a lot of different perspectives on approaches that may work best. So it certainly builds the relationship with the team, as Robin's pointing out, but really you find the most effective interventions by surveying all different staff, even staff from different shifts, because the night shift might say, oh, that problem's not a behavior for me, or that behavior's not a problem for me because this is what I do. And so now we've got everyone talking and participating and being part of the solution. And so as Robin pointed out, they're much more apt to buy into it if they've been part of it rather than just told.
Ownership in the intervention plan, and I think that really helps. Not a directive from any one person, but something everyone's contributed to.
Thank you. First of all, you're getting some comments in the chat screen. You're not able to see them, but people are really appreciating your responses. So thank you both for sharing your expertise. There's a question here from Becky. She said, I have seen some nursing homes post a social history of the resident. This was helpful to get to know the person better, but is it allowed, or is it a concern about HIPAA policies?
I can tell you how we do it. I can tell you how we do it on our dementia behavioral unit. We, of course, do a psychosocial assessment that's in the person's chart, but our CNAs, social workers, or our activity coordinator also completes a sheet called About Me, and it just has the first name on it, and it's more about those personal preferences that Robin was talking about. What's my favorite color? What kinds of activities did I like to do? Was I in the military? What are my kids' names? Where am I from originally? Things that we can use to devise conversation about, writing about that person's history, as well as activities that person might enjoy based on their past experiences. And we talked about different ways to do that, and even though it just has a first name, we talked about putting it in the person's room above their bed, which some facilities do, but in our case we decided that for that confidentiality that it might be better to put it in the CNA's ADL care book. So when they're looking up and documenting on ADL care, they have access to that information.
That's a great way to kind of get around the HIPAA. And I know what I've seen is when it's in the room that the resident and the family are deciding what they want to share with the staff. Seems to help where there's like this forget what the intervention is called, the tree of life or something like that, and on every branch there's something about the resident that they wanted to share with staff. There might be a picture of a lemon meringue pie and information about I love to bake or those types of things. So it's not so much the staff deciding what's going to be posted, but the resident and the family deciding here's what we want to share with you about what's important to this individual.
There are a couple more questions coming in, and we'll get to as many as we can. One person mentions that they like the idea of sharing these techniques with the CNAs, but they're sort of preparing themselves for the pushback that the CNAs are staffed and they're basically barely able to keep up with their basic care. In your experience, do the interventions you're suggesting take more time than care as usual?
Mm-hmm. Very good question. And training and communicating behavioral approaches does take time. But often, if we can get people to buy into the fact that if we're using approaches that work best with this particular resident, things like care, meaning showers, changing, are going to go more smoothly, then we often can have people buy in. I recently did in the nursing home where I consult, I recently did an in-service, and I partnered with our activity coordinator on this in-service on sensory stimulation. And so how I got people to actually want to participate is I did about them. So we played meditation, like spa music in the background. We had people come in and give each other hand massages with different scented lotions. We picked around different types of citrus for people to smell, and we made it more about just kind of a relaxation for staff and just kind of more of an informal discussion. And several people gave me comments that they felt really relaxed, that they really enjoyed it, and that the techniques they were using from an experiential standpoint, they were using them themselves. They could be more easily adapted in the work that they do.
Sounds like once people learn a different way of interacting with people with dementia around these behaviors and it becomes second nature to them, they can actually probably prevent problems and save time in the future.
Absolutely.
We did have a person write in and say that, going back to the issue about whether or not to put up information about the person, on their walls so people can see it, that as long as it's okay with the durable power of attorney, the resident has a right to share personal information. Mm-hmm. So you want to talk that over in your facility and see what the facility's perspective is, and then also to come about a way to continue to respect resident rights and to discern whether the resident wants to be more public or less public with some of this information. There was another question here. We have a male married resident. The wife is not here. He has become very sexual, a lot of public masturbation. His female neighbor, who is widowed, is now attempting to assist him with this need. Both have dementia. Keep them apart as much as we can, but they constantly attempt this. Any suggestions?
Well, their neighbors, the one idea might be to kind of move them in more of a distance from each other in the building. And so think, that if the person has more hypersexual behavior that is persistent, that it may behoove you to get order for behavioral health evaluation.
Okay. All right. Any other questions? There is one comment. Thanks for the information. Useful, practical. I work for a public housing authority, and our service coordinator are often the first people to notice changes in cognitive impairment, and we see this demonstrated in terms of disorganization around disrobing, wandering, agitated behavior. So thanks for the information.
Yeah.
Will be our final comment because we've reached the end of our webinar time. Robin Bonifas and Lori Waldberg, thank you so much for sharing your expertise, clinical acumen, and information and insights with with us today. And people, please know that this is being recorded, and the recording will be posted in about 24 hours. So thank you very much, and we're going to be concluding the webinar. Bye-bye.
Bye.